just share my presentation now, and we can, I think, start. So guys, please type yes in the chat box if you can see my screen. I hope you can see my screen now. Yes, please type yes in the chat box so that we can begin. Okay, great. Thank you, Dr. Subina, Dr. Sahitya, Dr. Akhil. Thank you, Dr. Anchal. Okay. Thank you, Dr. Jain. Okay, great. So let's begin. I will just make it full screen now and we start. So welcome to this 53rd Pain Journal Club. This is the first journal club for the season 2. And in this season, we are going to focus on the cancer pain mainly. Today we are going to discuss a very important paper. And before we begin, I'll just do the customary introduction. Pain medicine world over is having quite diverse issues and variable standards. There are different learning requirements and different offerings. Money and time is something which rather prevents the physicians from learning and understanding this branch, and as a result, practicing pain. Mumbai Pain School is an initiative by Panisha Spine Wellness and Pain Relief Center. And we are using online education platforms. We are using social media like Facebook. We've got a lot of video views every time. We've also started our Instagram page. Do follow us on Twitter as well. So most of our content is online and on demand. We have majority of our content is free. We have some paid content as well. We conduct hands-on workshop. In the last about 6 or 7 months, we have conducted 3 cadaveric workshops here in Mumbai. We are fortunate to have expert faculties from all over the world. It's said that the best teachers, they teach from the heart and not from the book. A journal club is nothing. It's just a club, with the difference that here we are going to discuss and critically evaluate the recent academic literature, which is going to be based on a defined subject. Attendee participation is extremely important, and we encourage you to ask questions in the question panel or in the chat box. They help us understand the topic better and maybe discuss and bring up a few new points as well. So it's tough to be regular. So try to be regular it's very, very tough to be regular. So try to be regular in understanding the journals. So journals have been very popular, and even Tinsley Harrison, he used to hold his journal club as well. And the purpose was critical evaluation of the academic literature. And we all know how popular this book is. Time and discipline is important, so I request the speakers to stick to their timelines. Healthy skepticism and praise is welcome. So guys, please, whatever you feel, just write in the chat box or do email me on mumbaiPainSchool@gmail.com. So you're most welcome. This is a bit about me. I practice pain medicine full time and I live in Mumbai. But today we have with us our esteemed faculty, a very senior pain physician, and now also the professor of palliative medicine in Tata Memorial Center. So I take the privilege to welcome Dr. P.N. Jain, sir. Sir, you are welcome. Sir is former professor and head of pain division, Anaesthesiology, Tata Hospital, Mumbai. He's past president, Indian Society for the Study of Pain from 2010 to 12. He's also done his international cancer fellowship in Memorial Sloan Kettering, New York, and John Hopkins, Baltimore in 97. He's got 87 pain publications in international and national. These are only the pain publications. He's got, to his credit, more than 200 lectures in international and national pain forums. He's a WHO expert on opioid policy guidelines, and he's also received the ICRA Best Research in Pain Award in 2016-17. And recently at Bhubaneswar, he was awarded with the Lifetime Achievement Award as well from the Indian Society for Study of Pain. So we welcome you, sir. I think he's joined.
Thank you. Thank you so much.
Yeah, I can hear you, sir. Great. So we also have today Dr. Sanjog Mekewar. He's a consultant interventional spine and pain physician at multiple hospitals in Pune. He's also a visiting consultant to BJ Medical College, again in Pune. He's the director of Jivisha Pain Management Center, again in Pune. And in addition, he's got a lot of interest in regenerative medicine and spine endoscopy. He's also got publications in national journals, and he's an avid traveler and explorer. So welcome, Dr. Sanjog. Dr. Sanjog, you can unmute yourself and you can say hi to all of us. Yes, yes.
Hello everyone.
Yes.
Thank you for the introductions.
Great. So now I request the first speaker, Dr. Sasmit, to start sharing his screen. And I hope, Dr. Sasmit, you can start sharing your screen now. Just let me know if there is an issue. We cannot see your video as well. Okay, now we can see your screen. Great. Yes. So you can start. Dr. Sasmit, we cannot hear you. Yeah. No, you're not audible. So there is some issue with your mic because from here you are unmuted. Yes, you have now joined the audio, I think. Yes. Now you speak again. No. So just disconnect and reconnect. No, I cannot still hear you. Can you hear me, Sasmit? No, I think this all is okay. We can see your screen, your settings and all is okay. You can just disconnect your audio and connect again. There is an arrow button next to the mute thing on Zoom. You can just click it, disconnect and connect. No, not here, on the bottom of your screen or maybe on the top. Can you mute and unmute once? Or maybe connect your headphone or something. Maybe that may change the thing. Meanwhile, let me check if we have Dr. Maitri so that we can immediately start with her. Okay. Dr. Maitri, I have promoted you to panelist. You can start your presentation if Dr. Sasmit is taking time. Can you hear me?
Yeah, I can hear you. Am I audible?
Yes, you are audible. So you can share your screen and let us start to save the time.
Okay. Sir, you'll have to.
Okay. Yes. Dr. Sasmit, yes, I can. Yes, I can hear you now. Yes.
Yes.
Share your screen. Let's try one more time. Then we
it's
go.
Coming visible, sir.
Okay, sure. I will enable. Just a minute. Yes. Now you can share. Yeah, I can hear you now. Great. So I can see your nice Goa picture. Is this a Goa? No?
Yes.
Okay, great. Please begin.
So, good evening, everyone. I'm Dr. Sasmit Lotliker. I'm doing my fellowship in pain medicine at Patil University, Navi, Mumbai. And today I'm going to present a special article on Indian Society for Study of Pain, Cancer Pain, Special Interest Group Guidelines on the Pharmacological Management of Cancer Pain, Part 1. This was written in the Indian Journal of Palliative Care by Dr. Raghavendra Ramanjulu et al. So introduction. As we know, worldwide, low and middle income countries are experiencing significant increase in cancer pain patients. More than 1 million cases have been diagnosed every year in India, and the incidence in advanced stage cancer being around 70 to 80%. 38% of all cancer patients have experienced moderate to severe pain, having a pain score of more than 4/10. The World Health Organization also states that drug treatment is the mainstay of cancer pain management in WHO pain ladder. Fourth step of interventional therapies has also been advocated to the pain ladder, and conditions of medical practice being different in our country, modified guidelines are hence required for better management of cancer pain in India. So what are the aims and objectives of the study? First, to develop separate guidelines for Indian patients to improve the management of cancer pain. And second, to provide the patient with minimally acceptable quality of life. So what are the methods used? Basically, 3 different methods were used. First was the literature search, in which databases like PubMed, Medline, Cochrane, Google Scholar, and Ovid search engine was utilized. Second, there was a conference discussion. Cancer pain management guidelines were discussed during the meeting of Indian Society of Study of Pain, that is the ISSP committee members. And third is the Delphi survey method. In this, the cancer pain management questionnaire was circulated to all ISSP members present at the meeting, and also by mail to all the ISSP members and IAPC members, that is Indian Association of Palliative Care members. Now, what are the results and discussion? In 1986, a 3-step analgesic ladder was launched by the World Health Organization, advocating prompt administration of simple analgesics and opioids to control cancer pain. The referral point for managing cancer pain often starts with this WHO analgesic step ladder. It's a 3-step ladder basically used by the physicians as a guide to prescribe pain medications based on the magnitude of pain experienced by the patient. The intensity of pain was classified as mild, that is less than 4/10, moderate 5 to 6 out of 10, and severe more than or equal to 7/10. This is the WHO pain ladder, which was devised by WHO in 1986. The WHO analgesic ladder integrated a 4th step of interventional therapies to the ladder. Also, there was bidirectional use was given by WHO. Ascending pathway allowed us for the use in chronic pain and cancer pain, while the descending pathway allowed for management of acute severe pain, uncontrolled chronic pain, and severe breakthrough pain. Evidence recommends that interventions are incorporated into the 4th step may be useful earlier in the disease trajectory rather than for when patients are refractory to the pharmacological management. Now, this present study guidelines were formulated based on the results which were obtained from various Cochrane studies, RCTs, and meta-analysis, and were divided into 3 broad headings. Step 1 is the management of mild pain. Here we basically use non-opioid analgesics. First one among this is paracetamol. It is a p-aminophenol derivative which exhibits analgesic and antipyretic activity. It can, when used alone, as a combination with adjuvants or in combination with opioids at any stage of the 3-step WHO analgesic ladder. It can also exert ceiling effect or maximum therapeutic dose beyond which the risk of toxicity increases with no additional analgesic benefits. 2017 Cochrane review suggested no evidence for the use of using paracetamol alone, and there was no high-level evidence for the use in step 1, that is management of mild pain. In regard to the opioid-sparing effect of paracetamol, although reduction in drug burden from large dosages of opioid was possible, there was no evidence to support the same. Also, there was no high-quality evidence to support or refute the use of paracetamol alone or in combination with opioids for the first 2 steps of the 3-step WHO pain ladder. This study hence has suggested a grade B recommendation for the use of paracetamol in mild to moderate pain, having a level 2A evidence. Next group of drugs is NSAIDs. NSAIDs again are divided into non-selective COX inhibitors, which inhibit both COX-1 and COX-2 enzyme. These include ibuprofen, diclofenac, indomethacin, and naproxen, and selective COX-2 inhibitors like celecoxib and etoricoxib. COX-1 enzyme blockade leads to the side effects like gastrointestinal side effects, antiplatelet, cardiovascular, renal, and hepatotoxic side effects. 2017 Cochrane review and many other comparative studies showed 26 to 51% reduction in the pain after 1 to 2 weeks in 4 out of the 11 studies. These NSAIDs also exert a ceiling effect, just like paracetamol, on the maximum therapeutic dose, beyond which risk of toxicity increases with no additional analgesic benefits. There was also no high quality evidence to support or refute the use of NSAIDs either alone or in combination with opioids for the 3 steps of the 3-step WHO pain ladder. Depending on the cause of pain, topical NSAID gels or patches can also be tried for analgesia. Hence, this study has suggested a grade B recommendation for use in mild to moderate pain, having level 2A recommendation. The next step is the management of mild to moderate pain. Here, we basically use weak opioid analgesics. The first among this is tramadol. It has mu opioid agonistic action as well as serotonin and noradrenaline reuptake inhibition action. RCTs suggested very low quality evidence that tramadol produced pain relief in cancer patients. It can cause serotonergic syndrome due to the effect on serotonin uptake. And there was no difference in the efficacy between tramadol, codeine plus paracetamol, and hydrocodone plus paracetamol, although tramadol was associated with more adverse effects. Tramadol also has a therapeutic ceiling effect, and there was increased incidence of side effects. The quality of evidence is very low to say that tramadol is not effective as morphine. And this study suggested grade B recommendation when used either alone or in combination with non-opioid analgesics having level 1A, 2A, and 2B evidence. Next drug is codeine. This exerts analgesic effect when metabolized to morphine via the CYP2D6 enzyme metabolic pathway. According to meta-analysis, more effective against cancer pain in adults than placebo, but there were increased risk of side effects like nausea, vomiting, and constipation. Codeine, just like tramadol, also has therapeutic ceiling effect and there's increased incidence of side effect as well. There was no evidence, however, that in moderate pain initiation of codeine alone improved the pain. And this study results suggested a grade B recommendation when used alone or in combination with non-opioid analgesics, having level 1A, 2A, and 2B recommendation. The next drug in this group is tapentadol. This is a novel centrally acting analgesic agent. It has dual mechanism of action, having mu opioid receptor agonistic activity and norepinephrine reuptake inhibitor activity. Tapentadol produces fewer opioid-related adverse effects at doses equivalent to the step 3 of analgesic ladder, that is more than 60 mg of oral morphine equivalents in opioid-tolerant patients with cancer pain, or after starting tapentadol with step 2 doses, that is less than 200 mg per day. It was well tolerated and effective and could be used for the management of moderate to severe cancer pain. Based on Cochrane reviews, there were limited effectiveness and tolerability of use of tapentadol. Also, the pain relief and adverse events were comparable between tapentadol and morphine group. So this study suggested a grade B recommendation when used either alone or in combination with non-opioid analgesics having a level 1A, 2A, and 2B evidence. So basically, there is no evidence that in moderate pain, initiation of all the step 2 drugs alone will improve pain. The next step in the management of cancer pain is step 3, which involves management of moderate to severe pain. Here, the strong opioids form the mainstay of treatment. First drug is morphine. Oral morphine is considered as the gold standard for treating moderate to severe cancer pain. It is the most widely available and prescribed opioid. Based on Cochrane reviews, most patients achieved high level of pain relief within at least 2 weeks. A small proportion did not achieve any adequate analgesia, and about 6% of the participants discontinued their treatment with morphine because of intolerable adverse effects. 95% of patients with moderate to severe pains, however, reported a decrease in intensity of pain by 14 days of use. This study results showed oral morphine as the first choice opioid for moderate to severe cancer pain, having a grade A level 1 recommendation. And also, intravenous or subcutaneous route of administration of morphine opioids is advised only when rapid control of pain is needed. The next group of drug is methadone. It is a synthetic opioid. It has high oral bioavailability, rapid onset of analgesic effect, long half-life requiring infrequent dosing, lack of active metabolites, and low cost. So all these are positive factors which can be used in management of pain in cancer patients. At higher doses of more than 100 mg per day, methadone can cause potentially fatal arrhythmias like torsades de pointes because of QT prolongation. It is not thought to impair any renal clearance. Hence, methadone can be used in the management of pain patients with renal failure. 2017 Cochrane review suggested methadone to have equianalgesic potency when compared with either with morphine, but having low quality evidence. This study, however, suggested no ISSP cancer pain SIG recommendations on the use of methadone. The next group of drugs are transdermal opioids. Among this, first we have fentanyl. Fentanyl is 100 times more potent as compared to morphine. When used as a transdermal patch, fentanyl absorption occurs first in the cutaneous microcirculation before entering into the systemic circulation. It is absorbed by highly vascularized oral mucosa and nasal membranes before entering the systemic circulation. But only a couple of studies have looked into whether this mucositis or xerostomia affects this absorption of fentanyl. Systemic levels of fentanyl are affected by cytochrome P3A4 inducers as well as inhibitors. This has to be kept into mind. And this study results suggested grade D, that is level 5 recommendation for the use of transdermal fentanyl when opioid requirements were stable. However, grade D level 2A recommendation was given for the use of fentanyl in chronic kidney disease stage 4 and stage 5, while transdermal had intravenous route. The next group of drug is buprenorphine. It is a semi-synthetic drug available as parenteral, sublingual, and transdermal patch form. Cochrane review suggested that buprenorphine can be considered as a fourth line option compared to standard therapies like morphine, oxycodone, and fentanyl. This study also suggested that buprenorphine is the safest opioid in chronic kidney disease stage 4 and stage 5 when used by transdermal as well as intravenous route, having a grade D level 2A recommendation. Also, there was grade A level 1A recommendation for the use of buprenorphine as a fourth line drug compared to standard medications. This is a summary of the recommendations given. So to conclude, the ISSP Cancer Pain Special Interest Group Guidelines on Pharmacological Management of Cancer Pain in Adults emphasize on the following points: the importance of 3-step WHO analgesic ladder, use of oral morphine as the first choice for moderate to severe cancer pain, use of transdermal buprenorphine as a fourth line drug compared to standard medications for cancer pain, and these guidelines need to be used in conjunction with patient assessment and may be individualized as per the patient's needs. So critical analysis of this article suggests that actual results which were derived from all the three investigative outcomes, that is conference discussion, Delphi survey, and literature search, are not mentioned separately in this article. The exact number of participants present in Delphi survey and conference discussion were also not known. And lastly, there was no evidence suggesting any variation from the international guidelines. So the take-home message is ISSP Cancer Pain SIG guidelines on pharmacological management of cancer pain in adults will help all specialties involved in cancer pain care in the safe management of cancer pain and to provide patients with a minimally acceptable quality of life. Thank you.
Thank you, Dr. Sasmit. So now we'll go to some of the questions we have. So Dr. Jain sir and Dr. Sanjog, should we take the questions now or should we club them and take them in the end? Or would you like to add something here? Or if you like to ask any questions?
So both the papers are same on the pharmacology, so we will discuss it later.
Sure, sir. Most welcome.
Later finish also.
Okay, sir. Okay, sure. So Dr. Maitri, you can now start sharing your screen. Thank you, Dr. Sasmit. One request, if you can keep on moving your cursor as you speak, sometimes we lose the track where you are speaking. So it's important that you keep on moving the cursor as you speak. So I will just make you the co-host. Dr. Maitri, you can start sharing now. And please also keep your video on, Dr. Sasmit and Dr. Maitri, when you are presenting. That will be nice.
Is it seen?
Yeah. I can see you also. I can hear you also. Very good. So please start screen share.
Yeah, 1 second. So 1 second, this is taking something.
No problem, no problem.
Okay. I am Dr. Maitri. I am the current fellow at Patil Medical College in Pain Medicine. And my today's article is Indian Society for Study of Pain, Cancer, Pain Special Interest Group Guidelines on Pharmacological Management of Cancer Pain, Part 2. This is written by Raghutota et al. And in April and June 2020, published in April and June 2020. So the main idea of this article is these guidelines have been developed based on the available literature and evidence so that it suits the needs, patient population and situation mainly in our country. And for that, a questionnaire based on key elements of each sub-draft addressing certain inconclusive areas where evidence was lacking was made available on the ISSP website and circulated by email to all the ISSP and Indian Association of Palliative Care members. These are the questions which it is mentioned in the paper as well, but just listed out a few. And according to this questionnaire, the guidelines have been prepared. I'll start with the guidelines. For the method used was literature search was carried out using PubMed, Medline, etc. The search included studies published in English language till November 2018, where the evidence is lacking. Emails were sent to the members of ISSP and Indian Association of Palliative Care members. So the first is prescribing and titration of opioids and initiation of the therapy. Prescribing analgesics alone, as mentioned by Dr. Sasmit, does not ensure patient achieves complete pain relief. A comprehensive approach is essential. Oral morphine is the preferred drug of choice for management of moderate to severe cancer pain. Number 1, history. A detailed history of patient, his disease status, social background, etc. is important. Various opioid tools such as opioid risk tool, Dyer score, that is diagnosis, intractability of pain, risk factors, efficacy of drug abuse, screening test, etc. should be used. This doesn't take more than 1 minute. A consent form of the patient or the caregiver, if the patient is not in condition to give the consent, is needed for the check of urinary drug testing in future. Next, we go on to who can prescribe these opioids. As per the NDP's Act Amendment of 2015, any registered medical practitioner can prescribe opioids. Just to explain what RPM is, it means any person registered as a medical practitioner under Indian Medical Council in Act 1956 or under any law for the registration of medical practitioner for the time being in force, registered as dentist under the Dentist Act 1948 or under any law for the registration of dentist at the time of being in force, has undergone training in number one, training in pain relief and palliative care for prescriptions of ENDs and opioid substitution therapy for prescription of ENDs for the treatment of opioid dependence. Next, how to write an opioid prescription. Number 1, the prescription should be written in capital letters with generic name of the opioid prescription. It will be seen on your right hand side of the screen. This is how it should be written. Secondly, its exact number of tablets that's been seen here. Injections or patches to be dispatched with timing and the route should be mentioned. The prescription should have 3 copies, 1 retained for the prescribing author, 1 given to the pharmacist, and 1 to be carried by the patient. The registered medical practitioner should sign at the end of prescription, write his or her medical council registration number. Next, we go on to how much opioid can be given during each visit of the patient. So that totally depends. Each institute or department can have their own policy regarding the prescription. The distance a patient has to travel, the type, the severity of pain, and other factors should be considered. Moving on, next is communication between the patient, caregiver, and the doctor before starting the opioids. The salient features of patient-doctor communication before prescribing any opioids. Number 1, inform about the around-the-clock medication, instead the PRN medication. Inform about the side effects and how to deal with them. Most commonly, we see sedation or constipation using morphine. The drug should be kept in safe place away from children. Patients can be given a card to keep the record of the tablets used. Patient may be asked to bring empty wrappers and remaining stock of the medicine to keep the check of misuse of opioids. Patient should be asked to come for follow-up before the opioids are completely exhausted. Moving on, how to keep a check on opioid abuse or misuse. Following steps each Each should be followed by each follow-up. Number 1, check the remaining stock of opioids by pill count, checking of wrappers, history of amount of medication consumed. Is there an inadvertent increase in the dose? Assess the pain and a disease status on each visit. Next, check if patient is getting opioids from other physicians. Third, check with pharmacist about the amount of drug dispensed. Fourth, is patient accompanied by a different caregiver every time? Next, how to start the treatment. The initial dose with opioid oral morphine, immediate release 5 milligram every 4th hourly, lowest dose in the opioid naive patients. 10 milligrams 4th hourly in patients already on step 2 of WHO ladder therapy. Third, in elderly patients, a dose of 2.5 milligram oral morphine, immediate release every 4 to 6 hourly has shown effective pain relief. Fourth, for patients receiving immediate relief morphine every 4th hourly, a double dose at bedtime may be recommended for convenience based on the consents to prevent being woken up by pain at night. 5, if patient presenting with severe cancer pain, parenteral titration of opioids can be performed for quicker onset of analgesia. Next, maintenance of opioid therapy. Regular dosing of opioid therapy round the clock is recommended in patients with chronic cancer pain. Once the effective 24-hour dose is established, the patient's pain is stable, the regimen can be converted to 12-hourly sustained release formulation to the equivalent of 24-hour immediate release morphine dose. Example, if a patient needs 60 milligram of immediate relief morphine in 24 hours, then we can give him 30 milligram of sustained relief morphine every 12 hourly. Patient is advised to take morphine immediate release for the breakthrough pain. The dose of morphine is increased by increments of 5 to 10 milligram if pain is not controlled. A combination of immediate release and sustained release preparations could be used to properly manage pain tailoring to individual patient requirements and attitudes. Next, every follow-up 5 A's must be assessed and document. Number 1, analgesia, meaning how is the patient's pain today? Activity of daily living, for how often and how long do you go out to the market or just walk, etc. Questions like that. Any adverse effect if patient is facing any aberrant behavior, such as patient wants early refills or wants to go for a vacation. And fourth, effect, how does the patient feel taking the medication? Next, breakthrough cancer pain. Definition of this is a transient exacerbation of pain that occurs either spontaneously or in relation to specific predictable or unpredictable trigger despite relatively stable, adequately controlled background pain. The prevalence is 39 to 80%. Standard prescribing for breakthrough cancer pain is use of the same opioid for the management of background pain as modified release or immediate relief formulations. Oral morphine has been conventionally prescribed for breakthrough cancer pains. Continuing, to provide fast pain relief with fentanyl, different formulations such as oral transmucosal buccal tablet, which is available in formulation of 200 micrograms in India, or buccal soluble film and sublingual and intranasal sprays have been used. The patient is advised to roll it against the inside of the cheek rather than suck it as a lollipop till they have adequate pain relief and discard the remaining amount of drug. The commonly accepted ratio of breakthrough dose of to the around the clock medication is 1:6. The rescue dose may be given as often as required, up to 1 hourly. The round-the-clock dose may be adjusted taking into account the total amount of rescue morphine taken in last 24 hours. Next important point is opioid rotation or opioid switching. This means the change from one drug, first-line opioid, to second-line opioid owing to the intolerable adverse effects accompanying the adequate analgesia or increasing side effects when the opioid dose is increased because of inadequate pain relief. The pain control was achieved 14 days after each rotation, and in most of them, the dose of the new drug introduced in each rotation needed to be increased above the dose initially as calculated from the analgesic ratio except methadone. There was no significant decrease in the frequency of side effects, but patients were satisfied. No particular opioid drug is found to be best suited. Now coming to opioid equianalgesic doses. There is no universal guidelines for the same. A common practice is to reduce the initial converted dose by 25 to 50% due to incomplete loss tolerance. This is a table which shows the opioids and their equianalgesic ratios. I'll show you with a example. Say we want to convert 60 milligram of oral morphine to 25 mics per hour fentanyl transdermal fat. This means the ratio of morphine to fentanyl is 100:1 as mentioned here, followed by, so this means 1 milligram of morphine is equals to 10 micrograms of fentanyl. And so if patient needs 10 milligram or 60 milligram of morphine in 24 hours, that gives us 600 by 24, 25 mics per hour dose of transdermal fentanyl. This is an example, but we have the table and we can use it for whichever drug we want to use. Follow. Now, the management of opioid side effects. Number one, and very common, constipation occurs in 40 to 90% of the patients. Detailed history is essential in preventing chronic constipation. Naloxone, nalmefene, methyl naltrexone is a peripheral acting mu opioid receptor antagonist. A newer class of agent addressing the peripheral effects of opioid has been approved for opioid-induced constipation. If intractable chronic constipation, opioid rotation to fentanyl or methadone should be considered. Non-pharmacological methods such as or reference to onconutritionist lifestyle changes, bedtime laxative, etc. can be used. Laxative basically do not target the underlying cause of the OIC opioid binding to the mu receptors in the enteric system, and as such are not very effective in managing the constipation. Next, nausea and vomiting. The etiology of nausea and vomiting in advanced disease can be multifaceted and includes cerebral causes, metastatic causes, etc. Has varied pathology, hence need to be directed by pathophysiology. Antiemetics such as haloperidol, levomethazine, etc. are used for the treatment of nausea and vomiting in palliative care patients. In example, in malignant bowel obstruction, Optride has been studied along with glucocorticoids, antipsychotics, antiemetics, and anticholinergic. It has been reported to have improvement in nausea and vomiting when started at the time of diagnosis, decrease the nasogastric tube drainage output, and provide good symptom control. Next is pleuritis. It is commonly seen with epidural or intrathecal routes of morphine administration. Treatments of its side effects hence depend on the postulated cause, which could be spinal opioid receptor, histamine release from mast cells, disinhibition of the itch-specific neuron. Antihistaminics such can be used, such as diphenhydramine and cetirizine are used commonly. If pleuritis persists despite adequate symptomatic management, then consideration of switching opioids should be entertained. Next is delirium. The presence of of various causes of delirium that occur in those who are terminal ill makes a diagnosis of opioid-induced delirium complicated. It should be considered as a part of differential diagnosis. According to a Cochrane review, opioids have less than 5% impact on delirium and hallucination. After that is sedation, occurs in 20 to 60%. The important point here is to differentiate between the cancer-induced fatigue versus opioid-induced sedation, reduction in the dose, addition of adjuvants, use of psychostimulants, maintenance normal sleep-wake cycle. A good sleep hygiene is important. Patients who have an altered sleep-wake cycle and those who have poor pain control affecting sleep will need educational adjustment to the analgesics for pain relief. This could lead to catch-up sleep, which could last for a couple of days and should be explained to the relatives. Number 6, respiratory depression is presented as increased somnolence, sedation are the first symptoms preceding respiratory depression, increased risk of complication when rapidly titrating or escalating the dose, careful monitoring of the level of consciousness is better indicator for early recognition of the respiratory depression. If respiratory depression is suspected, then a mu opioid receptor antagonist such as naloxone should be titrated as described. In a 10 ml syringe, 1 ml of IV naloxone, that's 0.4 milligram or 40 microgram plus 9 ml of normal saline is taken. Then 1 to 2 ml, that is 0.04 to 0.08 milligram, is given every 60 seconds until the reversal of symptoms are seen. The T half of naloxone is 30 to 80 minutes. Careful monitoring is required. Dose may be need to be repeated. If there is no improvement noted after a total of 1 milligram of naloxone, another reason for the respiratory depression should be sought. Reversal of respiratory depression from the buprenorphine requires a higher dose of naloxone. Conclusion: the guideline says oral morphine should be started in low doses every 4th hourly. Use of transdermal fentanyl as an opioid of choice for opioid rotation. Laxative should always be prescribed along with strong opioids, and naloxone should be used for opioid-induced respiratory depression. This is a table showing the recommendations that have been mentioned in the guidelines and the level of evidence that they suggest. Example, morphine started at 5 to 10 milligram dose 4th hourly is 2B level of evidence, and further on. So I would like to conclude saying that this guideline suggested by ISSP and SIG guidelines on pharmacological management of cancer pain in adults will help pain specialists, anesthesiologists, palliative care specialists, and others who are involved in cancer pain care in safe management of cancer pain and to provide the patients with minimally acceptable quality of life. Thank you.
Great. Thank you, Dr. Maitri. Now, I'll just have a look at the questions which are there. So guys, please type your questions in the chat box. And now over to Dr. Jain sir and Dr. Sanjog to conduct the further proceedings.
Thank you, Dr. Sidharth. So this is both are very good presentation by our students. Now, what is missing here, if you see the critical analysis, that these are the consensus guidelines of ISSP. According to the Delphi survey, according to the members, and according to the conference discussions. So I could not find any of those details, that how many people participated in this, in the Delphi survey, what was the conclusion of the Delphi survey, because these are the, ultimately you are saying that what is the Indian perspective of this? This is already known. Cochrane review evidences are already known that except the morphine, which has got level 1 and grade A recommendation, others are just 2B or sometimes 3 or even 5 recommendations are there. In large, if you see, in cancer pain, only 1% literature is RCT proven, beyond doubt. So 99% whatever practice in cancer pain is just experience-based or retrospective trial-based. So there is nothing, because these patients are generally advanced cancer patients. So research is very difficult in an advanced cancer patient because you cannot follow them up. You cannot have the biochemistry available periodically for safety issues, and you cannot call them in the clinic for seeing the responses. If you talk on the phone, then they may not understand the nuances of the, that you are talking of delirium. So what is delirium, or what is happening in the patients, whether it is opioid induced sedation or whether it is cancer related fatigue, you cannot differentiate unless you see the patient. Most of the patients in end of life, which you are receiving morphine nowadays in India, generally those patients who are in last year of life, earlier this was 6 months of life was said as end of life. Now it is gone into 1 year, up to 1 year. So if those who are having 12 months of life remaining, they are all included into end of life care, right? So those all patients remain at home and they come for fill up, refill. So we give them refill in our OPDs, in our Tata Hospital palliative care OPD. which I am managing nowadays. So we have about 100 patients per day in the OPD, and about 20 patients come for refill. Anybody who comes, and then we ask, and sometimes we make a video call, or sometimes we ask for a local doctor letter to give the witness or to give the justification or testimony that this patient is consuming that to prevent any opioid abuse or something like that. So those things, and otherwise we see the patient after 2 months. So continuously, we cannot actually, telemedicine doesn't allow us to give morphine on just video call. All the prescriptions can be given by the telemedicine, which is the act came into 2020, but morphine or opioids cannot be given by just on video call, right? So these are very good guidelines, but Indian perspective is missing, woefully. So I would have loved if even nothing could have come out of this, but they should have given that 47 people participated to Delphi survey, but their opinion was not different from the international guidelines or these, because research is that only, that what was done. In the material method, they have written that these 3 components are there of this research. So all these 3 components should have been written. Other expert.
Great. So Dr. Sanjog, you want to say anything, or we can take up the questions?
Yes. So first of all, very nice presentations, and sir has given a good summary and what to take from this article. I just want to say that if we talk about cancer pain, so the focus is more on treatment of cancer rather than on the cancer pain, what I've seen in my practice also. So that is the reason why we are getting patients in very late stages, and when it becomes very difficult to control the pain with medications only. And that's why we have come to the 4th step of the WHO ladder, that we are proposing. We have to do it early or in the 2nd stage, 3rd stage, whatever. So that is a very big concern that we have to look into. And that's all from me. We can actually take the questions now.
Okay, great. So let's take some questions. Dr. Firoz is asking how to start oral morphine with moderate to severe pain and in what dose. So I think Dr. Sanjog, you
Yes.
or
So we can start, we generally start morphine at 5 milligrams at 4 hourly interval, so that the good coverage is maintained throughout the day. If definitely the patient is elderly, then we can start with a lower dose, 2.5 milligrams. But generally the 5 milligrams 4 hourly is what we start with. And then we have to titrate accordingly. We have to ask the patient to take extra 5 milligrams or 2.5 milligrams for the breakthrough pains. And then we have to calculate in the week how much extra dosing is required. And then we have to upgrade the dosage of the medications.
Okay, so what percentage are you getting? How will you prepare 2.5?
Normally I give 5 milligrams only, because you get 10 milligram tablets of
but
yes.
Let me ask Jain sir, do we have a lower percentage if you want to give to, say like earlier there were solutions available also which could be titrated. So do we still have them now?
Solutions are there, but that has got a lot less expiry and chances of, actually it's a very highly concentrated solution. 1 ml contains 10 milligram.
Yes, sir.
So you have to give by a insulin syringe or by the dropper. Okay. So even 1 ml is 10 milligram. Really highly concentrated solution. And very few companies are making. Generally, older medical colleges were making this solution because it is coming at cheaper. The cost is cheap of the solution. If you make solution, the cost is very cheap. Our whatever we receive morphine from Cipla, and that is costing just 1 rupee per tablet, right?
Yes.
So 150 ml of morphine solution was costing 80 rupees only. So it is quite a cheaper preparation. But having said that, as Dr. Sanjog said that he is prescribing 5 milligram. So maybe that may be too insufficient if the patient is in severe pain,
Yes,
right?
so that's the
Because
point.
generally when you give morphine, that means tramadol is failed. That all the patients in cancer, they are prescribed tramadol by the oncologist if they are complaining of pain. So why they are coming to you as a last resort? So if you start with a very low dose, the patient will feel high and dry, and he will say that this doctor is also useless. First doctor could not control pain. This is also given me the wrong choice. They are not going into this that half tablet doesn't work, then I can take full. They don't take decision. They think that it is very dangerous drug or it is a very ये तो नशे की दवाई है, so I should not overdo it. So they won't take on their own full tablet. If you tell them that may they take, but generally I start if morphine tramadol is already failed, then certainly we would start with 10 milligram. Of course, the dose, if you say the Indian perspective, so I would not go for 4-hourly dose. I will go for 6-hourly dose. So generally in our pain clinic, 10 milligram, 4 times a day is the standard dose. And if the patient doesn't give even 50-60% pain relief, then that dose also, then we go for 4-hourly dose. Because in 4 hours, the Cmax is the duration of the drug, that start coming down. So you have to replenish the drug, right?
Understood.
So, and it takes about 2 days, or rather 24 to 48 hours to reach to the steady state concentration, right? So if the patient is taking 60 hourly, there is a hiatus, there is a breakthrough in between. So patient will not appreciate the pain relief when the patient is coughing, when the patient is walking to the bathroom, if the patient is lifting the arm, he will have breakthrough pain by the incidents. So he will not actually appreciate the good pain relief by morphine, right? If you take very low dose, right? So 4 hours is the key for giving morphine. If you want to give in low dose, then 5 milligram 4 hourly, but stick to the 4 hourly dose rather than 6 hourly or 8 hourly or 1 BD or 1 TDS. Let us go no pharmacokinetic.
Yes, the worst dose which I have seen is 1 BD or something like this, because yeah, the effect
then
will
they will say, this tablet doesn't work.
correct.
Because when you take morphine, when patient is having, that means patient will have severe pain, then he will take. Morphine takes 60 minutes to 90 minutes to act actually fully.
Yes.
So in that time, patient will suffer. And by 2 hours, the serum concentration graph starts coming down. So
Absolutely.
for 1 hour, he will have pain relief. And then again, he will go high and dry. So he will say this tablet is not good enough. So this actually prescription is not good enough, or this advice is not good enough, rather than the tablet is not good enough.
Correct. Agreed, sir. So one more question which Dr. Maitri has asked. So about the maximum dose of morphine orally. So there is no maximum dose. The dose of morphine is limited by its side effects. But let me ask a counter question to Dr. Jain, sir. Sir, what is the maximum dose which you have given in your practice? Because you have so many years of practice. So
about 400 milligram we have given.
Yes.
60 milligram tablet also comes. 30 milligrams also comes.
Yes.
So we have given 60 milligram tablet 6 hours, 6 hourly. So we have given quite a lot. So the patient was having a big bone tumor, and his thigh was quite swollen like a chest, and he was having severe pain. Young guy of 28 years old from Chembur. So we gave very high doses of morphine.
Okay, so let's go to the next this thing. I think there are a couple of comments from Dr. Taruna. So I will just read all of them. So they've said transdermal fentanyl in renal failure. So you should be cautious of escalation because the drug is not entirely in the bloodstream. So it cannot be dialyzed. So that's because we all know that fentanyl is very fat soluble, highly lipophilic. So that's the reason. So
only thing is that fentanyl metabolites are not active metabolites, like in morphine. The
morphine free gluconate and all that.
Six is actually 5 to 10 times more potent than morphine.
Correct.
And they need functioning kidney. So morphine should not be given in a incipient renal failure. And fentanyl also should be used cautiously in a kidney patient. But buprenorphine is very safe. Buprenorphine can be given in a patient who is on dialysis, because even then he will maintain his good pain relief, right? Because there is no active metabolite which is actually going by the kidney. It is all hepatic metabolism.
Correct.
So buprenorphine is safest for kidney patients. So we give Adnoc tablet 0.2 milligram thrice a day, sublingually. Very frequently we give Adnoc tablet. So whenever we find that this creatinine is 1.5 or 2 or something like that, or it is not normal, we don't know when the patient will come back. Suppose we give at 1.5 some fentanyl patch or something, and then patient after 3 days or 4 days or going into severe dehydration or kidney shutdown, or there is a urinary bladder tumor, and then hydronephrosis occurred, and then something happened. So we should not be caught on the wrong foot. So always use the safest analgesic, so you are not caught on the wrong foot.
Understood, sir.
Yeah, morphine can be used safely in the children. There is no problem at all. They tolerate very well. So 5 milligram, if the patient, generally they are, in children, generally they are blood cancers, but they are not so painful. And bone tumors are the other example. In children, bone tumors are common. Otherwise, other tumors are not that common. So in that, you require morphine only. They tolerate very well, 5 milligram, again 4 hours.
Great, sir. Another comment from Dr. Taruna again. So they mentioned that make sure patient doesn't have a bowel obstruction before using methyl naltrexone for obstipation.
It is not available in India.
Yeah.
Naltrexone. Yeah.
Yes, understood. But I think they just wanted to make comment because of the related topic. So point well taken. Okay, so we have more questions. Morphine in pediatric age group. Sir has answered this already. Okay, so Dr. Firoz says that fentanyl is 100 times more potent than morphine. Sometimes he has noticed that fentanyl infusion patients' pain will not be controlled. While with injection morphine bolus doses, their pain gets relieved. Is it so?
The difference between the fentanyl and morphine is that morphine is natural alkaloid, and fentanyl is synthetic drug. So, and it is a very powerful mu opioid agonist. Fentanyl is 100 times more on the mu agonist. Okay, so these are the pharmacological comparison, not the actual clinical comparison. Ultimately, drug is drug in your hand, and you are loaded in the syringe. So whenever you are loading the syringe, it is a dose which should be suitable for giving for severe pain positions. So at that time, so these are the interpretations for purpose of the pharmacology. So that is not important. So the difference between the morphine and fentanyl is that fentanyl is highly lipid soluble, morphine is highly water soluble, so it doesn't cross the blood-brain barrier. Okay, and morphine you give to the patient in casualty setting with severe pain, it will take 7 to 11 minutes to work, right? And fentanyl will work in 1 to 2 minutes only. So instantaneous, it will start working. And the patient will say, oh, I have no pain, but he will not enjoy like a scotch whiskey. In morphine, he will enjoy the pain. He will go into little euphoria. He will relax. He will calm down. He will say, this is the real 5-star hotel. This hospital is very good. That I am so good now. He will forget the disease. So those things are not there in fentanyl. Fentanyl will reduce pain. but not let him enjoy the pleasure of seeking this elixir. Right? So this is the two very different, and this is nothing, this is not from me, this is from Sebastian Mercandante. I asked this question to him in Italy when I visited there. So what do you use in your casualty setting when the patient comes with severe pain? Morphine or because he has a lot of publication. Mercandante is the father of opioids in the world. He has done maximum studies on opioid in comparison, in potency, in application. So he said these words, what I have said to you. So it is a cocktail of, or rather, very old whiskey. That is what morphine is. I am a teetotaler. I should not give these examples, but this is how it is to easy comprehension.
Understood, sir. This also brings us to another question, which is related to this effect of morphine. So, sir, in the end of life care, what other symptoms does morphine allay other than pain? This is what Dr. Maitri is asking. What is the difference in
breathlessness also? When the end of life is there, patient feel breathless.
Dyspnea is controlled much by
yes,
this.
So they feel, so a mechanism is not known, but if you start, so very low dose is required here. Here 10 milligram is not required. Here only 5 milligram, 3 times a day also will allay his breathlessness. Either due to anxiety is gone away, little bit of pain is also gone away, something happens into the mind, some receptor, because these are natural alkaloid. So many of the actions are there.
Okay, great. So I think this brings us to the end of today's thing. Dr. Jain sir, Dr. Sanjog, any closing comments before we just close?
I think sir's experience, it definitely, it is many things are there to learn from such great people with such great experience in cancer pain. So they know the minute details of everything, and how to actually practice, and how to give benefits, knowing the benefit, advantages and disadvantages, and knowing these minute details. So these are definitely a great learning experience for all of us. I think so.
Yeah, great.
And one more thing, a lot of Promedol is used. So people should not use the Promedol with ondansetron. Otherwise, ondansetron will neutralize the analgesic action of Promedol, and Promedol will actually neutralize the antiemetic effect of ondansetron. So they have both a drug interaction, both neutralizing each other. So one should not, at many places I have seen in the hospitals, they are mixing in the Promedol 100 ml normal saline dilution ondansetron also. So better, you should not use this, otherwise both the drug will be neutralized. Okay, that is important. And Promedol, when the patient is on Promedol, patient becomes sleepless. So they find difficult to sleep. So initiation of sleep actually. So if the patient said, I am, since we have started this painkiller, pain is all right, but now my sleep has gone away. So there the morphine works. So always, if you have both the drugs, and if you know that patient is okay, and I can monitor the patient, low dose of morphine is better than the high dose of Promedol. Right? So there are recommendations also. Yeah.
Sir, I have one question. If a patient is not tolerating even the small doses of morphine, and so what are the other options? If fentanyl and all those are causing very severe side effects in the patients, so what are the other options that you look for?
Other options, I have told you, buprenorphine is other option.
Okay.
And patch is other option. You start with 12 microgram patch or 12.5 microgram fentanyl patch. You start with, that is a children patch, and patient find very comfortable with that also, if they can afford that much, because this Fenistud patch of Ruzan company is 250 rupees and Johnson Johnson company is 450 rupees. So that price also matters. If you are writing very costly medicines, and they want 80% pain relief. So if that 80% is not achieved, they will say, nahi, bekar hai, wo patch bekar hai. If they find a good pain relief and the cost is not a matter for them, then they will say the patch is excellent. So give me the patch, 10 patches you give me. I will daily use patch. I don't want tablet. So all these things matter. What patient wants. Some patients say upfront that please relieve my pain, give me injection also, I don't mind. And some will say, I never want any injection. Don't try to give me any injection. Give me only some non-invasive treatment. So these things have to be respected, whatever patient says, and puts into the notes. So never try to give any nerve block, never suggest, otherwise patient will run away from your clinic.
Great. So I think we have one comment from Dr. Vishali. So she says that we start with the tablet buprenorphine sublingual. It also works good. So I think that's already mentioned. Then somebody asked about experience of methadone. Sir, I think you're using methadone now there in Tata.
Yes.
So
Yes,
just a few words.
We start with 2.5 milligram. Start with 2.5 milligram BD.
Yes.
Right? And then you escalate. Right? Because if the patient is having high doses of morphine, it is not working. And because it has got NMDA receptor antagonist activity also. Right? Only thing you have to do ECG before. You should do creatinine before. So little bit of some precaution is required because it can produce bradycardia or prostatitis. So for that, you have to see the patient has got no cardiac problem, patient ECG is normal, then you only prescribe for documentation and patient creatinine should be fine. Otherwise, it is kidney safe otherwise. Drug is kidney safe.
Great. So thank you so much, sir. Thank you, Dr.
Thank you very much for the invitation.
Thank you, Dr. Maitri. This was a nice discussion. And I hope all of you enjoyed, all the viewers joining from different parts of the country. And I think some viewers from abroad as well. So thank you, sir, again, once for your time.
The speakers, congratulations and very nice presentation.
Thank you.
Hard work. Thank you. Good night.
Nice, sir. So this is the season 2 of the Pain Journal Club, and we are focusing here on cancer pain and chronic abdominal pain. So we have first 4 journal clubs on cancer pain, and then we'll have a couple of sessions on chronic abdominal pain. So guys, this time we have a new time, 9:30 p.m. Don't miss this. We have group topics for seasons. We have 2 faculties and 2 papers throughout. Today I'm going to put up the papers in advance as well. So for the next step, the secret of getting things done is to act. So join our mailing list. Just go on to mumbaiPainSchool.net/news NEWS and please subscribe and join on our mailing list. WhatsApp group, I've already put in the link in the chat, or you can just email us for that and join our WhatsApp group. Our email address is mumbaiPainSchool@gmail.com. Suggestions and comments are most welcome. And please gear up for our hands-on MIPSIs, the upcoming cadaveric workshop from 16 to 18 September. And the registrations will open this week. So please gear up for this. And remember to join us next Friday at 9:30 p.m. Until then, thank you so much for joining in. Take care and wishing you a very, very, very happy learning. Bye-bye.